So we are honored to have Dr. Ashish Jha deliver our closing keynote address. Dr. Jha is the Dean of the Brown University School of Public Health, and he just completed a position at the White House as President Biden's COVID-19 response coordinator. Dr. Jha has been at the forefront of global health strategy and response for several decades, and rumor has it that he can also expertly craft 280-character messages. This is what President Biden had to say about Dr. Jha. As one of the leading public health experts in America, he has effectively translated and communicated complex scientific challenges into concrete actions that help save and improve the lives of millions of Americans. So imagine that in a letter of recommendation, and suffice it to say that Dr. Jha has been appreciated by many people. We're looking forward to hearing his thoughts today on global health and precision medicine. Welcome, Dr. Jha.
Great. All right, good afternoon, everybody. Thank you. And I know many people have traveled, as Zach said earlier, from around the world, but I appreciate Zach acknowledging that I had to come all the way from Providence, Rhode Island for this. If you have to deal with the greater Boston traffic, it's a whole different thing. So good afternoon, and look, I realize I'm the last main speaker before the end of this day. It's been a long day. It's been a really interesting day. I want to spend some time talking about the moment we are in and the work you all are thinking about and doing, and how they connect. So the moment we are in, we are squarely, in my view, in an age of pandemics. We have entered an age of pandemics. It has been very clear for the last 30, 40 years, number of novel diseases being introduced into the human population has risen steadily over the last 40 years. And this is a phenomenon that's not going to change. In 2015, I ran a course while I was still a professor at Harvard before I got kicked out. I had a course called Lessons from Ebola, Preventing the Next Pandemic. Professor Brandt was one of the key experts I spent time talking to in that course. And as I would have these discussions with experts from around the world, of course, it was in 2015, 2016 that we put it together. The question I would ask everyone, the last question that I would ask everyone, and by the way, this is all online, so you can go check it out, it's real. I would say, imagine it's 2020, and there's a global pandemic, a virus, possibly from China. By the way, in my mental model, had influenza as the virus, not a coronavirus. And the question I would ask is, would the world be ready? And almost universally, everybody said, unfortunately not. Now, was I a genius that I could figure out? Well, first of all, 2020 was just a random round number. It wasn't. But it was something we all were worried about. We were all worried that what we saw in the last few years was coming. It was incredibly predictable. So I want to spend a minute talking about why it was so predictable, and why none of the circumstances that led to this pandemic have changed. So why was it so predictable that we would get a global pandemic? Is it because, and what has changed? Is it because viruses have changed in the last 20, 30 years in a way that makes the world more susceptible? No, not that we know of. Has the human species become more susceptible to viral infections in the last 20, 30 years? No. So the genomic properties of the virus and the genomic properties of the human species hasn't really changed much. And yet, the world has changed. And so the question is, what's going on? And what is going on is that the circumstances, the context, the environment in which we all coexist has changed. And let me give you some more specifics on what I mean by that. So there are about 4 or 5 phenomena that have happened in the last 30 years that make this an area, an age, an era of pandemics. The first is urbanization. So the human species has been a largely rural species. We have, as humans, have lived in rural areas for our entire history. Even as recent as 1960, 2/3 of the world lived in rural areas. But that has been changing over time. And we think the inflection point was somewhere around 2005, 2006, when 50% of the world started living in urban areas, That number is probably about 56%, and it's going to continue to grow. So we have become an urban species just in the last 50 years. Urbanization creates all sorts of new susceptibilities to how a virus spreads, as you might imagine. The second is we have become a far more global species. If you just look at China, one of the questions is, why did I think China? Not because there's anything specific about China, but China has gone through this incredible transformation in the last 30, 40 years. If you look back to 2003, when the SARS-CoV-1 outbreak happened, compare that to 2019. Global travel out of China had gone up tenfold in those 16 years. So a virus that could have theoretically been contained in 2003 was uncontainable by 2019. And that's China, and I can give you a similar statistic for India, and I can give you a similar statistic for a host of countries on the African continent and Latin America. The whole world has become far more global. Third is about 80 to 90% of new viruses that infect humans, novel infections, are zoonotic in origin. This is not my way of weighing in on the origins of SARS-CoV-2 debate. Where did COVID start? It's a whole different conversation. I'm happy to have it if you want. But the truth is, in general, viruses usually jump from animals to humans. And the animal-human interface has changed dramatically in the last 30 years. Deforestation, migration has meant that humans and animals are coming into a lot more contact than they used to. And then layer in on top of all of this stuff climate change, and you have the situation you have now, which is predictably a world where we are going to see more outbreaks locally, we're going to see more regional outbreaks, and we are going to see more global outbreaks. That's where we are. So that is coming. That is the 21st century. Of course, the question is, how bad will that be? How disruptive will it be? Are we going to see the kind of disruption we saw over the last 3.5 years? And most importantly, what do we do to make sure we don't see the kind of disruption we saw over the last 3.5 years? Right? That's the question. So how big a deal this will be is largely up to us. And that's actually why I think the conversation you all have been having today is so incredibly relevant. Because we are not going to change the urbanization of the human species. We are not going to change globalization. We are not going to change. I mean, we should probably have less deforestation. I think that's something we should do something about. And yes, we clearly have to mitigate climate change, but climate change is here and it is going to continue. So the underlying factors that are going to drive pandemics is not going to change. So the only thing that can change if we want a different outcome, the only thing that can change is our response to it. And there are many facets of that response, but I want to talk about one right now that I think is particularly relevant to the conversation you've had today, that I think is particularly relevant to the entire topic. So when I look at the US response, and I'm going to talk about the global response as well, but when I think about the US response and what went wrong, a lot of things went right, and we'll talk about what went wrong and what went right. But when I think about the original sin, the original thing that got us on the wrong foot, got us going down the wrong path, that we never recovered from, it was the lack of precise data, the lack of clear data in the early days of the pandemic. In March of 2020, we had no idea where the virus was spreading. And by late March of 2020, we could see refrigerated trucks in New York and overwhelmed ICUs in Boston and Washington, D.C. And the response was a national response, right? The response was a national response where we had a national shutdown. And that made a lot of sense if you lived in Boston or if you lived in New York. But if you lived in Montana or Mississippi, it just made no sense at all. You looked around, you said, I don't see any COVID, because there wasn't any, not much. I don't see my hospitals filled, and yet I see all these public health restrictions. And for people in those areas, this did not feel right. It did not feel like the appropriate response. That lack of precise data, that lack of knowledge and information set up a lot of people to be susceptible to bad information, to a misunderstanding of what was happening, and it actually, I would argue, created the context for us to have a national response that was horribly imprecise, worked for New York, did not work for Mississippi. And we have in some ways never quite recovered since then. That, I think, has been one of the major challenges. Now, I want to talk about what data would have been helpful in March and April of 2020. What data would have been helpful in March of 2020, I think of as a couple of things. One is testing data. We as a country just failed to get testing up and running. Any kind of testing. You couldn't get a test. If you can't test, you don't know who's infected. If you don't know who's infected, you don't know how to manage an outbreak. Yeah? We had no testing data. The other thing that could have been very, very helpful is wastewater surveillance data. How many people are aware of what's been happening with wastewater surveillance? It's really like a phenomenal innovation of this pandemic. And I'll come back to talking about why it's been so great. You know, good testing data arrived about 4 or 5 months later. Wastewater surveillance data became more ubiquitous and widespread about a year later. But you know what data arrived about 4 or 6 weeks after the outbreak got really bad? Open table reservations data. I didn't just misspeak there. Anybody know open table? Restaurant reservations. Open Table did this really cool thing. They made their data on reservation rates in every city in America publicly available. You're like, he's going to connect this with a pandemic somehow, somewhere. I know it. It turned out it was the most useful data that I looked at for months. Because here's an interesting fact. When there was not enough testing data, and there was no wastewater data, and you had no idea how many infections were happening in a community, you could go to the open table reservations data, and you could see reservations in restaurants starting to fall. Because reservations in restaurants is a sign of people being confident about what's happening in their community. And when people started saying, oh, my friend has got COVID, and my aunt is really sick, people started not going out to restaurants as much. And so you could look at human behavior. And I literally remember being on a call with a governor and trying to explain to this governor why I was very worried about what was going to happen in that state in the upcoming weeks. And trying to explain that they had seen a dramatic drop in open table reservations data. And the governor was like, who am I talking to? Who is this guy? I thought he was some public health guy. So data comes at you from all sorts of interesting places, sometimes places you're not expecting. But that was an extraordinary source of information that made a very, very large difference. An example of precise data. So today's, this conference that's been going on, that Zach and team have been running, is on precision medicine. And in some ways, I feel like as a public health guy, I'm a physician too, but I primarily am a public health person. My job is to talk about precision public health. And so that open table reservation data is like an example of precision public health. Love precision public health. And I'm going to come back to talking more about precision public health. But before I do, I want to take a minute, because I think it's going to be important for the rest of this conversation. And by the way, I'm going to make sure there's plenty of time for discussion. So I'm just going to speak to you for another 10, 15 minutes, and then we'll have time for questions, comments, pushback, whatever you guys want. So precision public health, there's a formal definition. I'm going to see if I can pull it up. There are lots of formal definitions. The one that I like is, use of large-scale data to enable the right intervention at the right time for the right population. Right? It's really an intellectual extension of precision medicine, which is about using all the data you have to do much more precisely target interventions for the patient in front of you. You can try to do the same thing at a population level. Precision public health is wonderful, and I'm going to tell you that it was sorely needed in the pandemic. But before I do, I'm going to take a minute, and this may feel a little impertinent here, but I'm going to take a minute and extol the virtues of imprecise public health. Imprecise public health, broad public health, not targeted public health, actually has been pretty glorious over the last century. If you think about the big things that have changed life expectancy in the world, people live like twice as long now as they did 80 years ago, 100 years ago. Why? Largely public health. And if you ask what part of public health is all imprecise public health, sanitation, clean water, not targeted, not data-driven, clean air. Air is so much cleaner now than it was 40 years ago. Not precise, not only targeted in communities that are vulnerable to bad quality air. Air is cleaner for everybody. Childhood vaccines, universal. We don't just think about which kids are particularly vulnerable. We think every kid should be vaccinated. Right? That's imprecise public health. It's been awesome. It has saved millions and millions and maybe arguably billions of lives. It has been a source of great success. Fluoride in water, I have a whole set of examples. Iodine, seat belts. They're universal programs. They don't require data, thank goodness, because we lived in an era where data was very hard to gather. I'm going to talk to you about how, with precision public health, we have a lot more data. And so you can imagine, in that era of imprecise public health, we were able to make all of these gains. You can imagine if we try to do some of that stuff today. I mean, in the craziness of what has become, what goes for discourse in the public square today, can you imagine someone talking about, Jon Snow taking off the pump at the Broad Street pump? You guys have heard about this, like the classic. Somebody be like, where's the randomized trial that shows that polluted water is actually causing cholera? So we live in a very different era, but there was an era where interventions, writ large, writ broadly, made an enormous difference. And the two things that allowed imprecise public health to really, to do really well was you didn't need data, and you largely did not ask for behavior change. If you think about it, you don't ask people to breathe cleaner air in some ways, right? You put in policies that clean the air outdoors and everybody benefits and nobody's behavior needs to change. Same thing with clean water. Now, one of the examples I gave you, fluoride, same thing. You don't ask people to drink water differently. One of the examples I gave you, seatbelts, universal seatbelts, did ask people to change behavior. And now it's pretty routine, and I assume no one in this room thinks twice about putting on a seatbelt when they get in the car. 30 years from the time we had clear data that seatbelts save lives till the time it became universally accepted. So even something as seatbelts, if you're asking for behavior change, there is a lot of work that goes into it. It takes time, it takes effort. It's always worth remembering that when we think about the kinds of things that have gone on in the last 3.5 years of the pandemic, and we think, boy, it was so hard to get people vaccinated. It took 7 years to get 80% of kids vaccinated against polio. So these kinds of interventions are hard. Okay, so imprecise public health is how we've all been taught public health. I was taught public health 20 years ago. And we learned about interventions at a societal level, everybody sort of benefits. And that worked great until this pandemic showed up. And then the use of imprecise public health, I would argue, was a disaster. In March of 2020, we used a whole set of imprecise public health tools, and I would say that was a major cause of where things went awry. And if you ask the question, what do I mean major things went awry? Here we are 3.5 years later, more than 20 million people around the world have died. Obviously, millions have become disabled. Kids have fallen behind, mental health crisis, the economic impact. Again, I'm not going to go through all the ways in which the last 3.5 years have been terrible. You've all lived through it. But it has not been the public health response I think we all wish that we had had. And for me, when I think about what went wrong, it's easy to find villains. If we had a different president, if you live in the UK, you're like, if you had a different prime minister. The truth is, nobody did extraordinarily well. Some people did better than others. I'll come back to that point in a second. But nobody did extraordinarily well. And this is less about villains and more, in my mind, a public health model that just didn't work for the day we were in. All right. Sorry. So, trying to think about where I want to go next. So I've talked a lot about what went wrong, the lack of precise data, the having to turn to things like open table. It's easy to find all the ways in which things did not go right in this pandemic. But I want to spend the next 5 minutes talking about places where things did go really well, where the response, and most of them are from the United States, but there are examples of this from around the world, where we need to think about why those things were different, and then what the implications are for the longer run. And the three I was thinking about, the first is the issue of vaccine equity. So when vaccines started first getting rolled out in America in 2021, unsurprisingly, if you know our country, you know the structural inequities that exist in our country, you will not be surprised that we immediately saw a gap. Wealthier people getting vaccinated at higher rates than poor people, white folks getting vaccinated at a higher rates than black folks and Latinos. No surprise. The response in the administration, and then when I went and worked in the administration, we used the same tactic, was immediately every piece of data we looked at had to be stratified by race, ethnicity, income, local region, geography. We needed to deeply understand what was going on, what was driving those disparities. And then the second thing was we needed to identify the gaps, and then the third was to find people who could help us close those gaps. And early on, that meant partnering with barbershops, meant going out into communities where there was not a lot of trust, maybe rural communities, and working with religious organizations. But the bottom line was that the moment the response became data-driven, and very precisely and local data-driven, we were able to find gaps and close them. And if you look at vaccination rates and booster rates by race, ethnicity, income, big gaps, and they closed. That's data-driven precision public health. When I was at the White House, excuse me, when I was at the White House, I'm looking for some water. I'll find some. Paxlovid became widely available. And we started driving use of Paxlovid as treatment for more people. Thank you. And what we found very quickly, and again, you will not be surprised, is that the uptake of this new medicine was largely happening in wealthier communities, better educated communities. You have a new treatment, you push it out, guess who takes it up first? Right? The Newtons and the Brooklines, for those who live around here. I mean, it's just the reality. We could have said, well, that's terrible. Wish we lived in a different country where that didn't happen. By the way, that kind of stuff happens in lots of places. But the response was, okay, why is that? And what's different? And how do we begin to close this gap? So one of the things that was very clear is, just going to pick on Newton. I actually live in Newton. You know, most people in Newton have primary care physicians. Thank you. Now I've got all sorts of water. Look at that. Cold and warm water. I'm going to do a bit of mix and see which one works better for the throat. Little randomized trial right in front of all of you. Science in action. Okay. People in Newton, just picking on Newton, have primary care doctors. When they get COVID, they call up their primary care doctor. The primary care doctor calls in a prescription. It's great. You know, a lot of people and I'm going to actually talk about New York because we work with New York City on this. A lot of people in Southern Bronx don't. Turns out they don't have primary care physicians. And so the message of, if you have COVID, call your doctor, get a prescription, just doesn't work so well. But you got to have the data to know that. And then you work with the city, and New York City was amazing at this, by the way, to set up test to treat vans that would actually send vans into those communities and work with a local pharmacist. And so people could show up to the van, get a test, they're positive, get handed Paxlovid. And again, we saw what were initially large gaps in uptake close. The point being, if you use data in the right ways and you use it to drive action, data-driven precision public health really can make a difference. I'm gonna have to stop talking soon. Sorry. Last example I was gonna use. I talked about wastewater. I'm gonna share something that's a little embarrassing, which is I became known as the wastewater guy at the White House because I love wastewater surveillance. And I would talk about it all the time, and people at the White House were like, "You're weird." It's true, I am weird. Wastewater is extraordinary as surveillance data. Now, right now, just if you're wondering like what this whole thing is, I know some of you know about it, not everybody does. Right now, CDC is driving this program. About half of people in America live in a community where we're doing sampling of wastewater from those communities, and mostly measuring SARS-CoV-2. Sorry. Mostly measuring SARS-CoV-2. We need to expand that to more communities. But how much SARS-CoV-2 is in the wastewater is totally not connected to how much testing is happening, whether people are going out there and getting tested or not. So it's actually a great way to know how much infection there is in the community. And then when monkeypox hit last summer, Mpox now called, we could pivot and use wastewater data to figure out where monkeypox was spreading. And this data source becomes really important surveillance. Now, monkeypox, which was horrible last summer, is down to almost zero now because we're sampling monkeypox samples from around the country. And whenever you see a little bump, call up the public health department in that community, say, and they often say, "Oh, we're surprised, we've seen no cases." And then we say, "You're gonna see a case in the next week or two. So can we set up some vaccination programs?" Early warning, precisely targeted. You're not trying to vaccinate the whole country. You're identifying early on where is this happening and how do you counter it. That is precision public health. That did not exist 4 years ago. That is something we have learned in this pandemic. So it's easy to talk about all the things that went wrong, and plenty went wrong. But there have been just a whole series of lessons of what has gone right. All right, let me just make 2 more points and then I will stop. One is something that I think is at the heart of precision public health that has come up several times today. One, it's the notion of trust. Now, you heard about it from Dean Daley in his original remarks. If you go back to, for those of you who were here this morning and listening to George Daley's comments, he talked about trust. You heard about trust in the conversation about biobanks and how do you use biobanks in a way to really drive clinical care, public health. It is fundamental to a strong public health response. And let me share some data. There's a guy named Tom Boyke who's at Georgetown. He and a whole group of scientists did this study, published in Lancet about 15 months ago. And they had a very simple question, which was, why did some countries do better than others in the pandemic? Why did some countries have much worse mortality rates than other countries? And they looked at a whole host of factors. How many labs you have, how many doctors you have, how many ICUs you have. None of that actually panned out to matter much. One thing mattered: how much trust people had in government and how much trust people had in each other. Countries with more trust had lower death rates. It's interesting. I have a different version of this where I often talk about, what explains differences in death rates across countries once vaccines became widely available, kind of in late 2021. It's vaccination rates among elderly. See, it's the only thing that predicts deaths after vaccines became widely available. We talk about masking, you can talk about testing, you can talk about ICUs, you can talk about whatever you want. If you want to look at death rates in countries, it's how many people get vaccinated that matters. And at a time when vaccines are widely available, only one thing drives vaccination rates: trust. So precision public health is all about trust. All right, a couple of last points. One of the things we have seen in this pandemic is an explosion of data, just a massive amounts of data. And I often say I'd much rather live in a data-rich world than a data-poor world, and that is certainly true. But a data-rich world is not without its costs. And the explosion of data and the ubiquitous nature of data has meant that you can take almost any point of view you hold, like the Earth is flat, that the vaccines are killing millions of people, whatever you want to hold, and you can find data to substantiate it. Because there is a lot of bad data out there. Now, there are areas of genuine scientific disagreement. I have my views on vaccines and treatments. There are reasonable scientists who think I'm wrong, and we debate those things, and that's normal and good and healthy. But there's also a lot of nonsense out there. A lot of just bad ideas backed by bad data. And we are drowning in it. And we as a country and we as a world do not have a strategy for managing the sheer volume of bad data and bad analysis that is hurting us. And this is another major lesson of the pandemic. You know, we live in highly fragmented information architectures. We used to have a mental model. I used to have a mental model. I mean, I'm just like, I can't believe I'm going to admit this because it's so naive. But I used to have this like mental model in the early days of the pandemic that, you know, the scientists of the CDC would come out and tell people what the right answers were, and then everybody would listen, and then we'd all do the right thing, and then like it would be all okay. You may be like, wow, that guy's really naive. Really naive, I get it. Sorry, I'm gonna admit it. We live in a highly fragmented information architecture. What does that mean? It means all of us consume very, very different bits of information. I have my information consumption patterns. It's different than all of yours. Yours may be different than your spouse's. Your spouse's may be different, or your friends. And in that explosion of information that we have out there, there's a lot of junk information. People talk a lot about misinformation and disinformation. Like those terms have just become, I think, used in ways that are no longer useful. I really try to think about junk information. In my mind, junk information is like junk food. It's pretty tasty, right? We all love consuming at least a little bit of it. Admit it, we all consume some junk food and we all consume some junk information. That's okay. It's not great, but it's okay, right? The problem is that when your entire diet becomes junk food, or your entire information diet becomes junk information, that's when it goes from being tasty to causing you to become sick. Literally. You know, I think about the fact that right now, deaths from COVID are at some of their historically low numbers. About 100 people, 120 people a day are dying of COVID. Still a lot, by the way. And if you ask, who are these people who are still dying of COVID? Almost none of them are up to date on their vaccines, and very, very few of them use treatments that are widely available. So we have vaccines that are free and widely available, treatments that are still free and widely available, and people are dying because they're not accessing those things. That, in my mind, is the cost of overconsumption of junk information. And we all have an obligation to do something about that, to help people understand the sort of nutritional value of the information they're getting. And often we sort of look to other people and say, well, somebody ought to fix this problem. And one of the things I came to realize before I went to the White House and while I was at the White House is, there's no cavalry coming. No one's going to come fix this information problem for us. We're just going to all have to do it ourselves. And the best way to counter bad information is by spreading good information. And we all have to make a commitment to becoming spreaders of good information. And by the way, that means checking your own information diet and saying, how good is it really? And how much junk information am I consuming? And then how do I help people consume better information? And obviously, working with trusted messengers helps a lot. But here, it's got to be a technology solution as well. With AI, I can imagine that the consumption of junk information accelerates. I can also imagine that with the right AI tools trained well, we can help people consume better information. But that's up to us. It's up to us what kind of tools we build. All right, let me finish off by saying just a couple of things. You know, we are in an extraordinary time. I mean, if you think about the last 3.5 years and what we have done as a country, as a world, as a scientific community, when I think about where we are right now, 77 Avenue Louis Pasteur, and if you think about what's going on in about 500-yard radius, 500-meter radius, for those of you from outside the US, we've got these incredible labs at Channing, Children's, Brigham, Beth Israel, the medical school, doing extraordinary research, building tools that are going to transform people's lives. Some of the best scientific research in the world happening within this radius. And they're all going to be useless if people don't trust it, if people don't have faith in the scientific process, if people don't have faith in scientists. So an urgent part of our job is restoring that trust, restoring that faith. And so as we think about the end of this public health emergency, I mean, yes, COVID is still around, COVID is still going to be a problem. I do think we're through the emergency phase of this. I have really thought a lot about the fact that we have a path forward with public health. That with using precision public health, built on trust, using data, learning from imprecise public health, right? Which is that it's best if you do things in the background so people don't even notice. But if you gotta get people to change behavior, if you gotta get people to engage, giving them high quality information, helping them make better choices about what information they consume, working with trusted messengers. If we do all of that, then we're gonna come out of this pandemic much, much stronger in public health. And I think about the fact that we're at a point where there are two incredible revolutions, scientific revolutions happening simultaneously. And by the way, the Boston-Cambridge area is sort of at the heart of both of them. People in Silicon Valley may think that they are, but they're not. Right? We have a revolution of genomics and biology that is extraordinary. And then we have the data and AI revolution. And if we figure out how to harness these two things to build more trust, more faith in the scientific process, better knowledge, and a better ability to understand what is good information, how to consume it, how to use it, we can build a better public health that's going to lead to a lot more lives saved. And if that ends up being the legacy, a legacy of this pandemic, then that will indeed be a silver lining that we will all be thankful for. So thank you for having me here. I'm happy to take questions. I hope I have not gone totally over. I still have 10 minutes, 15. Thank you. Oh, cough drops. Look at that. I have cough drops, mints, I have cold water, warm water. I'm so good.
Thank you for your inspiring talk. So you talk about junk information and compare junk information to junk food. So my question is, what is the driving force of junk information? How do we deal with that? And does it have a positive effect? For example, junk DNA has a regulatory effect. And junk food, from evolutionary perspective, junk food is good in food sparse time.
So junk food is evolutionary what?
From evolutionary perspective, when food is sparse, so junk food is valuable.
Yeah.
So how do we deal with junk information in public health?
Yeah, it's a good question. Look, my view is we should acknowledge that junk information is tasty. Right? It's attractive. There's a reason why it's a reason why like potato chips are consumed. I don't know what other people say. I love eating potato chips. I try not to eat them so much, but they're very tasty when you do, right? The salt, et cetera, you get the point. Junk information, very much that. So I think it begins by acknowledging that. It begins, how do you, and there are people who want to go down the regulatory path of we should control how much junk information. I am much more skeptical of regulatory approaches here. I am much more of the belief that you have to train people to understand what is junk information. When we eat potato chips, no one I know thinks, boy, this is really healthy for me. This is like really nutritious food. You at least know you're eating potato chips. I want to begin by helping people understand they are consuming the potato chip equivalent of information. I think that it at least starts there, acknowledges kind of what makes it attractive, and then builds on tools to help people make better decisions. Thank you.
Hi, my name is Vishala Mishra. Thank you so much for this talk. I was going back to the end of your lecture. You mentioned building trust and promoting scientific literacy. So I was going to ask you a question about, can you elaborate a little bit on that? Especially if you look back to the pandemic, we got the messaging wrong. We made a lot of scientific progress. The development of the vaccines, for example, was magnificent, but we got the messaging wrong. And you talked about like segmenting people and feeding them information that they can find accessible. So how do you think about the better use of numbers, and how should governmental agencies think about using visuals and using numbers to promote scientific literacy?
Yeah.
And I know this is more a long-term question, but I'm hoping you can.
Yeah, it is a long-term question. It's a big question. Obviously, it's a complicated question. Let me share a few thoughts, though. One is, I really think a lot of this is about helping people understand the scientific process. What I mean by that is when you're confronted with a scientific question as a scientist, a novel question you haven't thought about before, or your novel virus you haven't seen before, it is rarely true that you have no idea what's going to happen. Yes, you have some idea. You have models, you have animal models, you've seen other viruses, you know how immunology works, you know how virology works, you have some sense of things. You also have humility to understand that every virus can act differently and viruses can surprise you. And so finding a way to communicate both of those things. And that's hard, because what some people want to do, and some scientists want to do, and I'm totally sympathetic to this, but it's not helpful, is just say, I have no idea. This is a novel question. Give me 6 months. I'll get some data. I'll come back to you. Well, that's totally useless in the fast-moving pandemic where you need an answer today. And then other scientists go the other way and say, I'll tell you exactly what's going to happen with this virus. And the problem with that certainty when you don't actually have it is if you get it wrong, you've lost your credibility. So a lot of, and I try to do this, and I'm confident I did not do this consistently and perfectly by any stretch, is try to convey uncertainty, explain process, say, this is my best estimate of what's happening right now. We will have more data, and when we have more data, if it turns out my assessment is wrong, I'll come back and update you. So you begin to build confidence in process. Government agencies have a very hard time with this. One of the things that we did do, so we saw this all the time when I was at the White House, is you could see a misinformation super spreader event coming. CDC was going to have a meeting. They were going to discuss certain things. And if you looked at the chatter of the people who are anti-vax, they were going to use that meeting to spread a whole bunch of misinformation. And if you wanted to get good information out, CDC-driven information, CDC scientists would have to put the information together. It would have to go through vetting. It would have to go through clearance. And they could get it out in 4 weeks. So we started doing things like pre-clearance. can't get rid of clearance. Clearance is an important part of government process. But what if you know what the topics are going to be that people are going to try to spread misinformation about? What if you get the CDC scientists to write up something, go through clearance, and now you have a clear document? And if you see that information spread, misinformation, bad information spread, you can respond immediately with pre-cleared information. So there are ways in which you can make government agencies more effective. But it's just a lot of work. But that's okay. Like, important things take work. So thank you. Yes?
Thanks, Doc, for the wonderful presentation. So my question is, taking the wide gap of precision public health as well as precision medicine between the developed nations and developing nations,
Yeah.
what type of support or investments should developed nations provide for developing nations for preparing for the next pandemic, including increasing data transparency and, most importantly, meaningfully implementing precision medicine without borders?
Yeah. Well, this is a pandemic where I would argue that it is not at all clear that the developed countries or the high-income countries necessarily did that much better than a lot of low- and middle-income countries. In fact, that's my way of saying there are a lot of low- and middle-income countries that did better than high-income countries. So the lessons of this pandemic have to be flowing in both directions. That's point number one. Point number two is there was a lot of very good use of data. And if you think about data that was generated, there's a lot of very good data generated in low-income countries as well. For me, I think we're moving into a world where it's less about scientists and experts in high-income countries transferring knowledge and much more about collaborations across countries and across experts. There's a lot of expertise in low and middle income countries that is growing and developing. And the only way to foster that over the long run is through more collaboration. So I think that's important. I certainly think country-to-country collaboration. When I was at the White House, and this is something that President Biden was very clear on, we wanted to be deeply globally engaged through international agencies like WHO, but also directly one-on-one. But in general, we're moving from a kind of patronage model of where America will help you to a model of partnership, collaboration, let's work on things together because you have something to teach, we have something to teach, and we have something to learn, and you have something to learn. And that model, I think, is going to be a lot more sustainable and better.
Thanks.
Thank you so much for a very stellar presentation. And my question is around the concept of precision public health.
Yeah.
Yeah, I'm a public health professional as well, and maybe about 10 years ago when I was in grad school, public health is more like prevention of illnesses, promotion of health, protection of lives at the community level.
Yeah.
So I'm trying to balance the nomenclature of precision public health as opposed to the one-on-one clinical medicine that we're so used to. Like, how do we try to digest the concept of, yes, the traditional way of looking at public health at the general level could transcribe into a precision public health like you've rightly articulated?
Yeah, it's a good question. And it feels like there is a tension. Let me try my best to address this tension. The public in public health is not one vast, large, monolithic group. When I think about America as a country, it is incredibly diverse. It has lots and lots of different communities. All of us belong to different communities. Each of us belongs to multiple communities. I belong to a community of academics. I belong to a different community of physicians. I belong to a community of people who live in Newton. I belong to a community of people who are like Indian Americans. I'm not going to go through all of my identities because that will be ridiculous. But you get my point. And precision public health, in my mind, begins by asking the question, what are the public health needs of someone like me? And I don't mean to pick on me, but let's just and then say, what are the communities that are going to help influence behavior in a way that's going to be healthy? What are the information needs of different communities? So maybe the physician community doesn't need this information, but maybe the Indian American community does. So part of this is really trying to understand information needs of communities, what communities people belong to, not treating the whole country as a monolithic, like all Americans need this, but much more targeted, much more crafted, and then finding the right messengers for that community. That to me is, in that way, it's borrowing from precision medicine, but it's taking it up to the next level.
Thank you. That's very helpful. Thank you.
Thank you, Ashish, for such a timely review for us. And thank you on behalf of the people for your thoughtful comments on CNN for a couple of years and afterward in a much less free environment of the White House staff. I'm Gil Oman. I was at the University of Washington as Dean of Public Health for a very long time, and then medicine and other stuff, government. Among the many topics you covered very engagingly this afternoon, there are a couple of omissions which I'm curious to know if you think they're even important. The first was the initial response about masks. Apparently, there was an inadequate supply of masks, and the CDC made up a story that how it wasn't a droplet disease and it wasn't necessary, and then all of a sudden we needed masks. That undercut credibility, I would say, seriously. And there were some people who thought otherwise. There was a guy at Virginia Tech who we cited in a risk analysis paper in 2020 publication date, written earlier, and so forth. So that's one. Second, Operation Warp Speed. I'm on the board of the FNIH. We're very proud of the role of everybody, all sectors that came together. However, it's not usually acknowledged that while the results for the vaccines were momentous, miraculous almost, and have implications for many other viruses, that the drug side was a disaster. And first there was hydroxychloroquine, of course, and then there was Paxlovid, which maybe provides one extra day of, one day of reduction of illness, which is often within the time it takes to get the prescription. And when I asked for a prescription, when I had my one episode of COVID, it took the conservative action of the head of ID at University of Washington, where I was visiting, to get on the phone and call me back and say, I want to countermand your prescription. If you're taking, I have to ask you a few questions, if you're taking Eliquis. I said, in fact, I am taking Eliquis. And it was a pretty easy decision, one extra day or one late day less compared with the brain hemorrhage of overdosing on Eliquis. It was a pretty easy decision at that point. But otherwise, there was really very little to show. Steroids were known before. There was also the intervention by the then president about hydroxychloroquine. But the FDA response was to put everything in this experimental use authorization. So even these magnificent vaccines, mRNA vaccines, carried that disclaimer, I would say, and put it in the same category with hydroxychloroquine. And I didn't hear anybody, not Tony or anybody else, point out that this was a mistake. And it should have been corrected real time because the level of confidence in these new viral vaccines was sky high, and yet it had the same dumb bureaucratic delay decision governing its approval. So you think those are relevant items?
Let me make a broader point. And look, there is a lot of looking back and thinking about the ways in which things didn't go right. And, you know, obviously for much of that time I was outside of government. For a year and a half I was in government. I'm confident that as I think back to a lot of the things I said, did, argued, a bunch of it turned out not to be right. But a few principles from a point, say, you're making. One is honesty and not trying to play 3D chess, and I'll tell you what I mean by this, is really, really important. So a lot of my public health friends do this. I want behavior X from people, and therefore I'm going to say this, because if I say this, then they're more likely to do that. And trying to play sort of pop psychology of, and I don't know what CDC was doing. And again, I wasn't there, and I don't know exactly what motivated how they communicated around masks. But as a general rule, if you want people to wear masks but there aren't enough of them, tell them that. And we all get tempted into this. I was tempted. I would see my friends doing this where they'd say, don't tell people not to do X because it will lead to Y. And my general view was, I am not a psychologist who can predict what a population is going to do. So I'm going to do what I know how to do, which is just like give people my best advice, tell the truth of what I know and don't know. And if that causes people to do things that they shouldn't, I'm going to feel a little bit bad, but not that bad, because at the end of the day, all I can do is be honest and straightforward with people. It is really, really important in a fast-moving pandemic where there's a lot of moving parts not to play this kind of 3D chess. I do think Operation Warp Speed was an extraordinary success. We can quibble around, and again, there were some issues with the treatment arm of this. If Janet Woodcock was here, who ran that, she would have her views about ways in which it was successful. There clearly were good things that came out of it, the monoclonals, for the time period that they were available. But for me, the big lesson of Operation Warp Speed was if you get academia, private sector, and government working together, you can solve big, complicated problems very, very quickly. Money helps too. Before I left the White House, we launched something called Project NextGen. Because the vaccines we have are as good as they are, we need better vaccines. We need variant-resistant vaccines. We need mucosal vaccines. And the private sector is not going to deliver them in time. And so we very much modeled it after Operation Warp Speed, trying to drive real progress. I think we've got to, and by the way, I worked for the Biden administration. Operation Warp Speed was a Trump administration thing. Like, whatever. Like, President Trump deserves huge credit for driving a process that led to life-saving vaccines in very short order. And we should all acknowledge that, and we should thank him and feel like that was great success, and we should learn from it and do more of that kind of stuff. So we've got to get out of partisanship on this stuff and acknowledge successes where they happen. I think Operation Warp Speed was one of the greatest successes of kind of science, government working together to really solve a complicated problem under very difficult circumstances. There are probably 30 other topics I did not cover, but I want to say thank you for obliging me and letting me spend time talking to all of you, and thank you for inviting me. And I'll turn it back over to you. Thank you, everybody.